Okay. Differential diagnosis and importance of early treatment. Yes. That, of course, there are many aspects around this. One aspect is, of course, at the research end, where regulatory, no, sorry, where we are looking at ERMs, where you're looking at cells which harbor actually a lot of importance to avoid that they become too solid in the psoriatic lesion. And there are discussions, of course, around anti-IL-23s, which are put forward preferentially as the treatment which is indicated for early active intervention. The science bit, of course, is growing, and on one hand, we have to be critical. I think it's very important that the news about the various treatments, not only the anti-IL-23s, the various treatments and the theoretical aspects, the pathogenetic, the immunopathogenic interference, that this literature is really important in our insight in early active treatment. And then, of course, through real evidence. For what is the no-nonsense real evidence that we can find out to what extent that it really makes sense, and maybe which patients, so biomarkers in this respect would also be very important, which patients to treat early on. And then there is, of course, the angle of the quality of life, of the cumulative life impact of psoriasis, where the chronic the chronic loads of psoriasis with respect to especially children inhibiting and impairing their development has cumulative damage to psoriasis. And I think these aspects are very important. There is, of course, in many countries, in view of the fact that the most active treatments and the most effective treatments are also the more expensive treatments, and these treatments come later on often. And in that respect, it would be quite interesting to know more about the broader knowledge, both on science, on clinical efficacy, on sustainable disease control, and that these aspects are very important. Coupled to that, when we say the audience, also the general practitioners, is early diagnosis. For early diagnosis helps for earlier on treatment, that the patients are recognized in this respect. So I really would propose to the group that we regard this area of early active intervention as important. We know also the problem is the definition. What do we call early active intervention? Half a year only psoriasis and more than 10% of the body surface involved? Or do we mean no, we should not keep on for many, many years with only topical treatments before we move to a systemic therapies? Many sides to this coin, very many sides, but I think the whole area is important.
May you allow that I may share a figure? I hope that's possible.
Yeah.
I don't know if this.
Yes.
Can you see that? Okay. This is our latest update that has been just accepted for publication, and that's exactly going along the lines you explained. And this is, for example, that we, as I said earlier, psoriatic arthritis is no longer a comorbidity; it's part of the disease spectrum, and we have three. What our concept is, we have at least three domains of psoriatic disease. This is skin inflammation, vascular inflammation, and joint bone inflammation. And when you, as you said, when you decide to accept that psoriatic disease at the very moment a person has its first psoriatic plaque is a systemic disorder, we should not waste time for early diagnosis and early treatment, but treat right away.
Yeah.
Preferentially with systemic drugs. If you do so, you need to test the drugs for their ability to improve skin inflammation, vascular inflammation, bone joint inflammation. This is the future concept. When you have such drugs and all the biologics, the anti-TNF, the IL-17s, and the 23s do fulfill the 3 criteria, then you have a concept to start with. And when you do so, there is already data, particularly for the vascular component, but also for depression. When you do this kind of treatment, you also improve comorbid conditions. Having said this, I think the concept of differential diagnosis and early treatment no longer can be separated, but if you treat according to the concept of psoriatic disease 2023, you start systemic treatment with drugs that are around fulfilling these criteria as early as possible. And maybe we can also discuss around this a little bit more, because I think in the future, this early treatment needs to be defined for the first, and second, then it needs to be much more data. And the data, unfortunately, can only be generated in very, very long-term studies. 1 year is definitely not sufficient. 2 years is not sufficient. May even 5 years will not be sufficient. And this will take a very long time.